talk a little now about the Pulmonary Arterial Hypertension Treatment Guidelines, or the PAH as it's abbreviated there, treatment guidelines. So the first question is, what are these things? Well, they're documents that guide healthcare providers on diagnosing and treating a disease. They're not so much like a recipe, right? A recipe might be something you do when you're baking. You add the same ingredients over and over, same temperature in the oven, you cook for the same time, and you get something that's very predictable. Guidelines accept the fact that people are a little bit different. They're not exactly like baking a cake. You can't have the same recipe for every person, but it does give us some guardrails and some ways to say this is the practice patterns that are suggested and likely to achieve the best outcome based on what we know. And on the right side there, you see an example of the 2015 European Society of Cardiology, ESC, / European Respiratory Society, ERS, guidelines for the diagnosis and treatment of pulmonary hypertension. Now, who develops these guidelines? Well, top experts in the world who stay informed about research, often involving thousands of patients. So it's not just their own experience of who they're treating in their own group, either at their own center, but it's what they're reading. It's often the research that they themselves are involved in. And examples of meetings that have produced these guidelines are the World Symposium on Pulmonary Hypertension, the European Society of Cardiology, European Respiratory Society, as shown over there on that right panel, and the American College of Chest Physicians. Now, for someone like myself practicing on the East Coast, if I ever wonder, I wonder what Dr. Melendrez would say. I wonder what one of my colleagues in California who practices an expert center would say about this. I can't reach them on the phone immediately. I can't catch them by email in front of a patient, but looking at the guidelines often gives me their impressions as a consensus with others of how people are thinking about a specific area. And it's also a good touch point. If the patient says, well, is there a reason you're taking this approach? I can tell them about my personal opinion and what I think of the medical literature, but citing a set of guidelines gives it the weight of a group of my colleagues who are very knowledgeable about pulmonary arterial hypertension, and I can explain that to them as the reason why I'm making a recommendation for diagnosis and/or treatment. So why do we have them? I've explained a little bit of it already, but guidelines help you or help us ensure that you receive consistent, effective care. They help us stay on top of advances in care and best practices. Now you see over there on that right panel, another example from the American College of Chest Physicians. And these guidelines are produced at slightly different periods of time. So there might be one meeting that occurs last year, one that occurs this year, and one that occurs next year. And so just that slight variation in the research occurs between each year might give us a little different insight into how this group of experts answers a question. Now, it's not like the Supreme Court. It's not the same group of people each time that do this. It's a group of experts that often changes a bit with a lot of overlap. And so when you add in a few other voices, you often get a little nuance of opinion. I wouldn't say the guidelines are really ever in conflict, but slightly different nuances or variations in approach are sometimes seen between the two guidelines. So especially read by someone outside of the field, it might seem like there isn't any consensus on some of these items, when I think actually what you're seeing is slight variations on a theme. So what do these guidelines say? Well, the 2018 World Symposium on Pulmonary Hypertension Guidelines said something very important, which is that most newly diagnosed patients with PAH at low or intermediate risk status should be treated with oral combination therapy. So something that can be taken by mouth, the oral piece, and combination, 2 medications up front as part of their treatment regimen. You see a little asterisk right there. It has the footnote at the bottom that according to the treatment guidelines, initial monotherapy may have a role in treatment for certain patients. So if someone was started on one medication, that's not in violation or inconsistent with the guidelines, but it doesn't describe our approach to treating the majority. So if you talk about a practice like mine or many experts with whom I speak with, our goal for many of these patients is to start most newly diagnosed patients on an oral combination upfront, or meaning in the early period. That's if they're low risk or intermediate risk. Now, if they're high risk patients, an infused prostacyclin class medication, one of those that's given by pump, often with a catheter, a tube in the vein, or a needle or some device into the skin, that medication class should be included in those patients because they've been shown to be effective for patients in a high-risk state to improve their functional class and their state to a lower risk state. That is from high risk to intermediate or low. Now, it's important that whatever point at which you start, so let's say you're on a dual oral combination, you're taking 2 medications by mouth, that every 3 to 6 months to the right side of that panel, a risk assessment is performed. Now, if you were in intermediate risk status, which is not our goal is always low risk status, and you took dual oral combination therapy and you improved to low risk status, that suggests that we're on the right track and the effectiveness of the medications for you is moving in the direction we want it to be. If, on the other hand, you're in intermediate risk status and at a 3 to 6 month follow-up, and when you first start on medications, I tend to weigh a little bit earlier on that range. I don't want to go more than 6 months, but I'd certainly go closer to 3 months when I can to stay in that range. That visit, if it shows you're still in intermediate risk, I might be making a decision whether or not, like the bottom says, you're not yet at low risk, we may need to change to dual or triple combination therapy. So my example, if you start on the dual combination, which is where most patients are going to be treated, and you've not yet achieved low risk in the follow-up, I might want to add a third agent, and you would then be on triple combination therapy. So why these multiple medications? Well, think of it like if you had to bring your car in for repairs, and you might say there's several things that aren't working well, it's not running at its best. You could certainly decide you're just going to start with one thing and see how the car is running, but if it's recommended you need spark plugs, an oil change, and a brake adjustment, you might decide all those things are important to keep the car running well, so you'd ask the mechanic to adjust all of those things at once to keep things rolling smoothly. Multiple medications in PAH take advantage of the fact that we know that there's multiple pathways, and research has shown that taking multiple PAH medications can keep patients healthier longer. As you see there, an analysis of 17 studies involving more than 4,000 adult patients found that those taking multiple PAH medications had a 35% lower overall chance of getting worse than patients who were taking only one medication for a PAH. So if your risk status was up here, taking multiple medications lowered it by more than 1/3. That is 35% reduction in the chance that you're going to get worse. Now, certainly if we have a disease such as PAH that's incurable, we want to keep you in low risk status and not progressing. So that's an important thing to make sure that you're not getting worse and try to give you the best treatment regimen when we can. That analysis quoted also showed that multiple PAH medications helped improve the 6-minute walk distance, that hallway walk test back and forth, sometimes in the hospital or in the physician's office. And that helps reflect for us whether or not your functional capacity, your ability to walk and have your breathing work well, not have you be too winded, are all moving in the right direction. So a longer walk distance suggests that you're functioning better. It may improve functional class, sometimes abbreviated as New York Heart Association, NYHA, or World Health Organization, WHO. The functional classes are 1, 2, 3, 4 again. 4 is the worst. If you were, say, a functional class 3, we would like to see you improve functional class to a functional class 2, or if possible to a functional class 1. And multiple medications improved the chance that that could occur. We also want to reduce the risk for PAH-related hospital admission. No one likes to be hospitalized, and in PAH, that suggests that we can't manage you effectively as an outpatient or just through the office, that you need to be hospitalized. So minimizing that chance, or at least reducing the risk of it, is an important thing we are trying to achieve. Now, certainly today, we have multiple treatment options that offer us quite a bit of flexibility. It's much more than we had 5 years ago or even 10, 15 years ago. So you see the types of medication listed there. You have phosphodiesterase type 5 inhibitors, or PDE5Is, soluble guanylate cyclase stimulators, SGCS. I don't suspect you say most of those two phrases very often, but sometimes the abbreviations are used. Prostacyclin class therapy, often abbreviated PCY, and endothelin receptor antagonist therapy, or ERA. How do we give these medications? Well, there's multiple ways they can be taken in some classes and not so many for others. So on the PDE5 or SGCS, there's only medications that can be taken orally, or that is by mouth. In the prostacyclin class, the medications can be delivered by all 3 routes for which we currently deliver pulmonary arterial hypertension medications. That is, they can be given orally, they can be infused, or they can be inhaled where the medication is delivered directly to the lungs. And then there's endothelin receptor antagonists, or ERA, that are, again, only oral therapies, that is, those taken by mouth. So why is the right combination of those treatments so important? Well, the right combination may help you improve symptoms. That may help you feel more confident about running errands. It may help you feel more functional doing things in your home, whether it's chores, things you enjoy. It may help slow disease progression. Very important. PAH is unfortunately currently an incurable disease. So if we can slow the progression of that disease, we are moving in the right direction and trying to keep you as healthy as we can for as long as we can. And that's why the right combination is important. It might also enable you to do more in your day. So you can be out there with family and friends. Certainly in the present environment, the amount you can get out and about and the risks involved are somewhat of a challenge. But the idea is if you want to get out and take a walk and you can do that safely, that's the type of activity we want you to be able to do and promote that type of healthful behavior, because generally the better you're functioning and feeling, the better you'll feel about your life. Now, many patients might say, I don't like the idea about more medicine, but I want to improve my symptoms. And that's why the right treatment combination is so important. I'm going to talk a little now